Good afternoon, and welcome to today's webinar titled Clinical and Economic Impact of Central Venous Catheters. My name is Amy Barden, and I will be the moderator for today's session. At Teleflex, we believe no one should suffer from the consequences of preventable vascular access-related complications. That's why we partner with healthcare facilities to offer a comprehensive, consultative approach to vascular access. A couple of housekeeping rules and reminders before we get started. The live chat for today's session is disabled. You can enter your questions using the Q&A tool at the bottom of your screen throughout today's presentation, and there will be time at the end to answer many questions that may come in. Please also complete the survey, which will appear after the webinar is complete via a link. If you miss this link, you will also receive it in a follow-up email in addition to a recording of this session. This recording will also be available in the future on Teleflex Academy. Central venous access devices are associated with significant risks related to infection, which result in poor patient outcomes and economical impacts in your hospitals. From current evidence-based recommendations to specific device and technology comparisons, this webinar will provide you with a better understanding of the prevalence and significance of central line-associated bloodstream infections, and will also offer recommendations aligned with major guidelines on mitigating these risks. We are today to have Dr. Paul Marik as our speaker. Dr. Marik is board certified in internal medicine, critical care medicine, neurocritical care, and nutrition science. He is a professor of medicine and chief of the Division of Pulmonary and Critical Care. He has authored over 450 peer-reviewed journals, 80 book chapters, and 4 critical care books. He is cited in over 36,000 peer-reviewed publications. In addition, he has delivered over 350 lectures at international conference as a visitor professorship. He's also the recipient of numerous teaching awards, including the National Teacher of the Year by the American College of Physicians in 2017. Last but not least, he is the second most published physician in critical care medicine in the world. Over the next hour, Dr. Marik will share his detailed account and experience with catheter selection and the results experienced, as well as his recent publication related to device selection in your hospital. I am now honored to hand it over to Dr. Marik.
Thank you, Amy, for that very kind introduction. So as you've said, today we're going to be talking about central venous catheter bloodstream infections. And the objective of this talk is to understand the prevalence of infections associated with central venous catheters. We're going to review key decision points and application of risk mitigation strategies. We're going to compare and contrast device characteristics that impact infection. And we're going to review real-world data-driven results of a risk mitigation approach. So why is this important, and why are CLABSIs important? Well, according to the CDC in 2018, there were close to 25,000 catheter-related bloodstream infections in the US. This does represent, though, a decline from the previous year, but clearly this still remains an important infectious complication. Why this is so important is really twofold. Firstly, it impacts terribly on the patient. It increases length of stay, length of time in the hospital, and the patients suffer significant complications, which can include death. From the healthcare system, the implications are quite significant, as central venous associated bloodstream infections are the costliest hospital-acquired infections, estimated at about $45,000 per catheter-related infection. So clearly the impact to both the patient and the health system are significant. What we have witnessed over the last few decades is a constant decline in the CLABSI infection rate. You will see for gram-negative rods, for Candida, for Staph aureus and Enterococcus, the major pathogens, there's been a continual steady decline in the risk of infection over the last 2 to 3 decades. However, as you'll notice, the lines don't reach zero. So catheter-related bloodstream infections still remain an important problem, and we require multifaceted strategies to reduce these even further. So this is a table looking at the pathogens involved with catheter-related bloodstream infection, and clearly for a number of reasons, this data is really important. So this is data from 2017 from close to 4,000 hospital-acquired infections. So the most important or the most common pathogen is coagulase negative staph at 16%. And obviously, as we'll see, this becomes a problem because the clinician has to distinguish between a true pathogen and a contaminant which occurred at the time of blood sampling. Obviously, the one way to prove that this is a true infection is to have recurrent or multiple blood cultures which show the same pathogen. But there are other techniques we'll talk about. Then we have Staphylococcus aureus, Enterococcus, Candida species, Klebsiella, E. coli, Enterobacter, and Pseudomonas. So this becomes important because often when catheter-related bloodstream infection is suspected, you don't know what the pathogen is. And therefore, you have to treat with antimicrobials that cover this entire spectrum. And obviously, that's very important from a clinical point of view. As we'll talk about, when you suspect infection, you take out the line, you do cultures, and then you need to start broad spectrum antimicrobials, which cover all of these potential pathogens. As I said, Staphylococcus, the coag-negative staph, is one of the commonest blood cultures. The problem is how to distinguish from a true pathogen or a likely contaminant. So this was a study we did looking at over 1,700 blood cultures, and we related this to the procalcitonin taken at the time of blood sampling. So you'll see in those blood samples that had no growth, the procalcitonin was low, the normal value being about 0.5. However, you notice that patients who were diagnosed as having likely contaminants had a significantly higher procalcitonin, 1.27. So what this suggests is that the procalcitonin may help you distinguish a true infection from a contaminant at the time of sampling. Most hospitals are able to do a procalcitonin as a rapid test with a rapid turnover time. So the presence of both coagulase negative staph and a high procalcitonin should therefore raise the suspicion that this is a true catheter-related infection. So CLABSIs, as we said, are not a minor event. And the first approach, or the first rule, which really goes across the board of infection, is source control. So source control consists of prompt removal of the catheter when the suspicion is high, and obviously even before the CLABSI diagnosis is proven. So in a patient whom you suspect CLABSI, i.e. patient has an indwelling catheter, patient has a fever, has a white cell count, has increased procalcitonin or other signs of infection, the prudent physician will remove the catheter. Attempts have been made to salvage the catheter with antibiotic lock and systemic antibiotics. However, this is not recommended, as we'll see in the next slide. So the treatment is significant. So for uncomplicated CLABSIs, so these are patients without metastatic disease, the treatment for coag negative is a week. For the other pathogens, staph, enterococcus, and candida, requires 2 weeks of therapy. So consequently, you can see why this prolongs hospital stay and increases costs. Patients who have complicated CLABSIs require treatment for 4 to 6 weeks. This was a study in which they tried the antibiotic lock and systemic antibiotics and basically found that infection was 7 times less likely to resolve than if the catheter was removed. So I think the basic line is if you suspect infection, you remove the catheter. So do you know what your CLABSI rate is? And this is important for every hospital to know, and for particular regions of the hospital, the ICU, to know. We can see that the CLABSI rate in the US decreased from 3.6 to 1.5 infections per 1,000 central line days between 2001 and 2009. So we use the denominator is central line days per 1,000. So this provides a benchmark which allows hospitals to compare their rate with those of the national standard. So clearly it's almost impossible to reduce the rate to 0, but clearly you want your rate to be as low as possible. And if you aren't achieving those targets, then one needs more aggressive techniques are required to prevent catheter-related infections. So now we're going to talk about prevention of CLABSI. And I think the bottom line is this is a multifaceted approach. There's no single one intervention that reduces the risk. So one needs to do this complete package. It's a package deal. So how do you prevent CLABSI? Obviously, number one is hand hygiene and gloves, maximum sterile barrier precautions. So the days when one used little mini drapes is no longer acceptable. You need to fully drape the patient. In terms of skin cleansing, chlorhexidine rather than povidone iodine. Just remember that the skin is a likely source of pathogens which go down the tract of the catheter. So one really needs to use the best antisepsis one can. Then one needs to consider antiseptic or antimicrobial impregnated catheters. It says here for 5 days, but we'll come to that later. Then chlorhexidine type dressings. Most importantly, no guide wire change and no routine catheter change. This is really important. There are hospitals that still, for reasons that are somewhat mysterious, routinely change the catheter. That is no longer acceptable. So what one does is one daily assesses the patient to see whether they still need a central venous catheter and to inspect the catheter site. If they need the catheter, there's no need to change the catheter. The catheter stays in until either you diagnose and suspect an infection or you can remove the catheter. So what about antimicrobial protected catheters? These are now recommended by a whole host of respected third-party guidelines, which includes the CDC, Society for Hospital Epidemiology, the Infectious Diseases Society of America, Infusion Nurses Society, OSHA, and et cetera, et cetera. So it has now been accepted as almost as standard of care to use antimicrobial catheters. So going to skin antisepsis, which obviously is the most important first task to reduce the risk of pathogens on the skin. So this was a study comparing chlorhexidine versus providone iodine. This was the clean study. You can see a significant lower risk of catheter-related bloodstream infections when skin antisepsis was performed with chlorhexidine. Consequently, chlorhexidine alcohol should be included in all bundles for the prevention of catheter-related bloodstream infections. So next we come to chlorhexidine impregnated dressing. So this is a dressing which is impregnated with chlorhexidine and should be transparent so that one can actually see the catheter entry site. So this is a meta-analysis of a study comparing studies comparing chlorhexidine versus control. Just for those of you who are not familiar with, this is a forest plot. The line down the center is unity. So if the cumulative treatment effect crosses 1, it's not significant. If it's to the left, it means it favors chlorhexidine. If it's to the right, it favors control. So you can see this meta-analysis shows significant reduction in the risk of catheter-related bloodstream infections using dressings that are impregnated with chlorhexidine. You can see the odds ratio is 0.6. So a significant reduction in infections. So this was an interesting study looking at the stepwise change in the reduction of catheter-related bloodstream infections in red with incremental changes in the techniques for bundle management. You can see starting up here, the infection rate using a chlorhexidine sponge, and then progressing to chlorhexidine gel. So that is the favored approach now, and one can see that with time, as they ramped up their prophylaxis measures, the risk of CLABSI reduced significantly. So basically what we're talking about is a bundle, a set of interventions which must be applied together to reduce the risk of CLABSI. This was a meta-analysis in the Lancet showing the benefit of a bundled approach versus some variant thereof, and showed that when one introduced or used the entire protocol, the entire package of interventions, there was a significant reduction in the risk of catheter-related infections from 6.4 to 2.5 again per 1,000 catheter days after the bundle. So I think the standard of care must be a comprehensive bundle to reduce the risk of CLABSI. So what's the role of catheter impregnation, coating, or bonding for reducing central line infections? So this was a meta-analysis done by the Cochrane collaboration, regarded as the leaders in evidence-based medicine and performing meta-analysis. So this was an analysis of 57 studies. You can see it spanned a number of decades. You can see that this is 57 studies here, and this was the control group, 57 per 1,000 to 35 per 1,000. So this is a risk reduction of 0.62. Patients 40% less, more likely to have a reduction in the risk of infection with an antimicrobial catheter. So you can see 10,000 patients, and they rank the evidence. It was the highest level of evidence. So this was graded according to grade as high quality evidence. So based on this, there's exceedingly high quality evidence that the use of antimicrobial coating or bonding significantly reduces the risk of catheter-related bloodstream infections. So again, this is another meta-analysis. So the top is chlorhexidine sulfadiazine impregnated catheters versus no impregnation. And again, you can see the mean treatment effect is to the left of the line of unity. The risk ratio is 0.73. So again, a significant reduction in the risk of catheter-related infection using this catheter. However, these are studies using silver platinum carbon impregnation versus no impregnation. You can see that the treatment effect crosses the line of unity. So that means that the treatment was not significantly different. So we next get onto a controversial issue, and that is the site of placement of a central venous catheter. For reasons which are somewhat obscure, the CDC and the IDSA still have this recommendation of avoiding the femoral vein for central venous access. And consequently, many hospitals follow this recommendation, which, as we'll see, is completely incorrect. So this was a meta-analysis that we did based on observational studies and a single randomized study looking at the risk of infection between femoral and subclavian and femoral and jugular, and basically found no statistical difference between catheters placed in the femoral versus the subclavian or IJ. And that really leads up to this study. So this is a really important study because this was a prospective randomized controlled trial in which patients were randomized equally to the subclavian site, the jugular site, and the femoral site. And you can see this was a large randomized study done in France. What's important is they looked at the risk of mechanical complications, deep venous thromboses related to placement of the catheter, as well as bloodstream infections. So you can see overall, the risk of complications was lowest with the subclavian, then the femoral, and last the jugular, which is somewhat interesting because most hospitals prefer or recommend jugular placement as their choice of placement of lines. When one looks at bloodstream infection, again, we see subclavian has the lowest, but surprisingly, femoral was lower than jugular. And this is important because there is this erroneous misconception that the risk of catheter-related bloodstream infection is higher with the femoral as opposed to the jugular. And clearly, this is incorrect. The advantage of the femoral is that it's a useful site for clinicians that are really inexperienced in catheterization, who do not have the expertise for subclavian or jugular placement, because clearly it's impossible to cause a pneumothorax or pneumomediastinum when you place a catheter in the femoral vein. So it's often a very safe place to place a catheter, particularly for those inexperienced. And clearly this study highlights the complete misconception about avoiding the femoral site, which has no scientific basis. So next we get to the question of when to place an antimicrobial catheter. These are from general guidelines, which recommend placement in patients with limited access, patients at heightened risk of CLABSI, patients who are neutropenic, burns, critically ill people, patients with an expected dwell time of 5 days. The bottom line is when you place the catheter, it's often very difficult to know how long the patient is going to require the catheter. And just from a logistic and pragmatic point of view, it makes much more sense just to use the same catheter for all patients, i.e. to use an antimicrobial catheter. It creates enormous confusion when you have 2 or more catheters, and the idea of then placing a non-bonded catheter and then changing it to a bonded catheter, as we said, significantly increases the complication risk. So as a general operating procedure, it makes much more sense just to use an antimicrobial catheter in all patients. So that leads on to our study. So this was a study published in Infection Control and Hospital Epidemiology last year. We had the unusual circumstance of being able to perform the study. So what we did is we looked at the rate of catheter-related bloodstream infections at baseline using the Arrow central venous catheter. There was then a change to the Vantex Centurion central venous catheter. And then just to strengthen the association, we went back to the Arrow catheter. So this is a classic example of a before, after, before study, which holds quite high statistical significance. And what we found, you can see the number of infections over a similar time period in the before period. When we switched to the Vantex catheter, there was a sudden upspike in the number of infections, and these included atypical pathogens, including fungi. And then when we switched back to the bundle using the CVC, obviously now following very strict precautions, you can see the dramatic reduction in the risk of CLABSI. So this is a classic before, after, before study, and was highly statistically significant. So as we said, the cost of a catheter infection, a CLABSI, is about $45,000. So you reckon in the cost of this conversion cost the institution over $400,000 just from switching catheters. So what one has to recognize is that not all catheters are equal and that they are quite different. So the so when we talk about the AeroGuard Plus catheter, this has chlorhexidine sulfadiazine externally and chlorhexidine intraluminally. And when we talk about intraluminally, we're going to talk about the hubs and the extension tubing. This differs quite significantly from the Vantex, which only has the intracutaneous part that is covered with silver ions externally and intraluminally. In terms of guidelines, the AeroGuard Blue has a CDC 1A recommendation, whereas the Vantex catheter does not meet these current recommendations. And as we said, the catheter protection differs. The extraluminal surface of the AeroGuard and a complete intraluminal fluid path, whereas the Vantex is only the extraluminal surface is protected. So when one looks at the pathogenesis of catheter-related bloodstream infections, one of the most important entry points is the catheter insertion site, which allows skin microbes to then track down and colonize the catheter. So obviously, therefore, the catheter needs to be coated on the external surface, because the external surface of the catheter becomes colonized. However, what we've also now recognized that it's not just the external surface of the part of the catheter within the skin, but the hubs and tubing become an important source of colonization and infection. And here we see typically colonization of the intraluminal catheter surface. So again, the two different catheters differ in the approach to antimicrobial activity. The AeroGuard Blue has protection of the hub, internal fluid pathway. The extension tubing has internal fluid protection, whereas the indwelling subcutaneous part has both external and internal protection. And this differs significantly with the Vantex catheter, in which the hubs and extension lines are not protected. Furthermore, the antimicrobial activity of the AeroGuard is quite extensive. So as we discussed, this is the spectrum of pathogens which one's likely to associate with catheter-related bloodstream infections, which includes Candida and yeast species. And the AeroGuard catheter provides antimicrobial activity against all of these pathogens, and this persists for a long time. And this differs from the Vantex catheter, which has less extensive antimicrobial activity. So what I'm going to show in the next slide, this will be a video, a biofilm video. And what you will see is the performance of 3 central venous catheters. A non-antimicrobial central venous catheter, which is the control, a chlorhexidine and sulfur-silvadiazine treated antimicrobial catheter, i.e. the AeroGuard Blue Plus catheter, and then a silver carbon platinum catheter, which is the Vantex catheter. All 3 catheters were challenged with Staphylococcus aureus, which, as we know, is one of the most common and clearly pathogenic of all organisms.
Real-time video recordings under a confocal microscope simultaneously shows the surfaces of the catheter segments for 24 hours. The recording shows how much of the green fluorescence producing Staph aureus will adhere, colonize, and form biofilm. On the left is the non-antimicrobial control catheter segment. In the middle is the antimicrobial AeroGuard Blue Plus catheter, and on the right is the Vantex Oligon catheter. Bacterial colonies start to develop within 2 hours on the Vantex Oligon catheter segment and within 7 hours on the non-antimicrobial control segment. These colonies continue to grow and rapidly change into biofilm form. At 16 hours, the entire Vantex Oligon segment is completely covered with biofilm, while the antimicrobial aerocatheter segment remains clean and free of any visible bacteria throughout the 24 hours. You may notice after 16 hours a decrease in the green fluorescence on the Vantex Oligon catheter segment. This is due to detachment of the continuously growing biofilm in the circulating medium. Imagine what this detached biofilm would do if it occurs in the bloodstream. Biofilm shedding into the bloodstream can lead to a catheter-related bloodstream infection. What is of note here is how quickly this can occur.
So I think that video very graphically illustrates that the differences between the catheters are extremely real. So not only are different segments of the catheter are coated, but obviously the antimicrobial activity differs quite significantly. So this is the example of the ErgoPack complete system. So obviously what you want is a tray that has all the components that are required for performing the bundle. And you can see this is a comprehensive kit which is available. So the bottom line is that using this catheter, you protect your patients, the hospital protects their income. That the AeroGuard catheters are proven to reduce CLABSIs, catheter-related bloodstream infections, which, as we can see, cost over $40,000 per incident due to pharmacy charges, catheter days, additional days in the ICU, days in the hospital, lab tests, increased hospital stay. And that doesn't take into account the morbidity and mortality which patients suffer. So in summary, I think one has to remain focused and vigilant on recording and reducing catheter-related bloodstream infections. There are multiple pathogens that are involved. It's important that the epidemiology and infectious disease profile of the pathogens in your hospital be recorded, so you have some idea how to treat these up front. One needs a comprehensive approach to prevention is needed. As we said, you need to follow the whole treatment bundle with all elements of the bundle. I think we've clearly demonstrated that antimicrobial catheters make a difference, and furthermore, the choice of antimicrobial catheter makes a significant difference in further reducing the risk of catheter-related bloodstream infection. So if you require additional resources on this topic, they are available at this website. In addition, these are some of the references which were highlighted in this talk.